Okay, so to be able to predict the response to fluid therapy, because wouldn't you like to know that in your patient before, you know, who's going to respond to some fluid and who's going to get sicker, has become a new target in hemodynamic monitoring, and that sounds quite fair. And here we are, we don't need any really, we've just got a monitor happening here. We don't need any fancy bits of equipment. We have an arterial waveform, and we actually have the ventilator plugged in as well, and sometimes you have that in some units. But you can actually tell when that occurs, as you can see the respiratory swing here. Yeah, and really what you can do, and Michard here, he was the first guy that ever did anything about this. Mind you, for years we've known that if you've had a patient that's had a bit of a swing on their arterial pressure, that they're actually crispy. But he actually did some science about it. And you can actually print it out on your, this is at 6 millimetres per second rather than 25. You can put it all close together and you can actually work out what your pulse pressure difference is between the swings. There's a calculation you can do, which is 100 times by the difference there, over the difference divided by 2. I mean, you know, you could do that, but I tend to eyeball it. I think, yeah, we've got more than 10%, 13%. Yeah, so you can do that, and you can do it in real time. In fact, you can go to your monitor and you can change it to 6 milliseconds and slow it right down. You can actually see that if it's more than 10%. If you have concern about your patient and you think that they've got some hypoperfusion happening, and if they're preload responsive, so if it's, you know, about 13% swing, you know, they probably could do with a bit of fluid. Now, that was pulse pressure. This is systolic pressure variation, and of course it's similar because we're just looking at the top of it, the systolic pressure. And if that's about 10% difference, then you can know that they'll take some fluid quite well. One thing about systolic pressure variation is you can actually put someone, if they're well perfused to the fingers, and mainly that would be in someone who's got sepsis, because other types of shock, they'd be cold and your pulse oximetry wouldn't work. You can actually see the swing from your pulse oximetry, and if that's anything like 10%, then you know that they need some fluid. You don't even have to have them with an arterial line. So, moving on, stroke volume variation can also be seen through an esophageal doppler. And there's a new nasogastric tube out now that actually comes with a doppler that's positioned in the right spot, and you can actually do your doppler as part of your routine care, and that picks it up even better. And you can see the stroke volume changing here. You can see this is the stroke volume here, it's just upside down to what the arterial waveform is. Yeah, okay. And you can do this through an echo as well. You can see that anything, this patient here has a swing of 23%, you know, in there. They're actually very dry. Interestingly enough though, if you did someone's CVP and you measured it against their cardiac index, okay, you can see that there's no relationship at all between your CVP and your blood flow. So it's a little bit hard to work out. The CVP is really about the fluid potential, whereas the cardiac index is actually about what's actually happening. So they're measuring two different things there. So we can't use CVP as a surrogate for flow and for perfusion. Okay, so we've done our clinical exam and we've looked at basic hemodynamic monitoring, and we've assumed that we've given a bit of fluid if they're fluid responsive, and we still suspect that there's some global malperfusion happening in terms of shock. We need to then look at cardiac output and cardiac contractility. And there are different ways we can do this in a minimally invasive way. Before a pulmonary artery catheter, we could use, as I said, the esophageal doppler, which, you know, if that's on a nasogastric tube, hey, great. Pulse contour analysis with a PICO. You've all heard of the PICO system. And an echo, of course, we could have done too. And a lot of places do resort to echoes, and I also see a role for nurses in doing echo as perhaps a nurse practitioner one day. So if any of you want to go on and do something, that's a role that I think would be really good, is to have a bedside, go around bedside to bedside doing echoes all the time. Good. So we've talked about pulse contour analysis and your stroke volume, what that means in terms of cardiac output, and these are the three systems that use it: the PICO, the LIDCO and the Vigilo. And they estimate the cardiac output by using a special calibrated technique with some logarithm results. The PICO uses cardiopulmonary dilution, LIDCO does the lithium chloride injection, and Vigilo uses historical controls. But they all work and they're all validated and they're all minimally invasive, which is good. So perfusion again, how do we know if we've given fluid, if we increase systemic flow with improving cardiac output and fluid, do we increase tissue perfusion? And this is looking under the tongue. You can actually see that under the tongue, that the blood flow in the microvessels under the tongue is very sluggish. And when you actually will perfuse someone, you can actually see those blood vessels stand up and flow quite well. You know, so it's always something to be said for mouth care. All right, so we can measure cardiac output, and we have normal values of cardiac output. But how do we put that into the clinical context of the patient? Because sometimes their cardiac output has to be quite high for them to compensate, and sometimes it's quite low, and sometimes it's normal. So again, how do we work out what's normal for the patient? I mean, we have it indexed to their BSA, so their height and weight. So the cardiac index is 2.5 to 4.2. But, you know, again, if you have sepsis, you will have a high cardiac output at some point, and the other times you may have a very low one. It depends on what part of that trajectory of sepsis that you have. Cardiogenic, you know, maybe you have, at one point you may actually have a high cardiac output or cardiac index as a compensatory type of thing, but then it just falls away to nothing. We have obstructive shock and hypovolemic shock, which tend to be below because of volume and because of obstruction. But they all have treatment implications, so it has to be in clinical context with your patient. So we like to look at stroke volume too, but that again is independent of heart rate. And even though we have stroke volume index there, on these type of, now like the PICO and the LIDCO, they actually have the stroke volume listed all the time, as well as the SVO2, that tends to be constant. So those sort of things are really useful. And this is about measuring cardiac output with your echo, so I'm just showing you that can be done. And the problem with cardiac output, it doesn't put in to the equation contractility. Remember, so we had contractility over here. So let's have a look here. Two different patients, two different echoes, and we actually did their stroke volume and cardiac output with an echo. This is case one. They have a stroke volume here of 67 mils. Their cardiac output was 4.9. Case two, this person here was someone who was in multi-organ failure, not very well. This is someone who'd had an overdose overnight and was woken up. Their stroke volume was 68 mils as well, and their cardiac output was 4.9. 9 litres per minute. But what that doesn't show is that the sicker heart can dilate to accommodate a bigger volume. Yeah, you can see that accommodates that, which then reflects in your ejection fraction, which is your contractility. So, you know, that's, and the normal injection fractions 55 to 70%. We often have those that are just perhaps a bit lower than that and they still do okay. But we need to target contractility, and we can do that with different types of inotropes, like dobutamine or, you know, depending perhaps some electrolytes. Okay, so we're doing all that, and we've gone right through it, but we also suspect our patients so sick that they have pulmonary edema with their lack of perfusion. What types of patients do you think they would be that have a pulmonary edema with their shock state? Yeah, cardiogenic shock, of course, but that's cardiogenic pulmonary edema. There's also non-cardiogenic pulmonary edema.
COPD? No.
ARDS is what you're thinking of? Yeah. Yeah? No? You're thinking...
They can, but we are still thinking about vascular artery.
Yeah. Yes. I mean, there's lots of states that can cause that. In fact, if you have an infection and you have a massive inflammatory response,
yes,
you do get a lot of inflammatory changes at the lung and the lung pulmonary bed. Yeah, so you can get pulmonary edema just because, and so a lot of that stuff won't give you that information. And we do look at the X-ray and go, bit fuzzy. And what does that measure? Not very much objectively, but we can sort of have a ballpark figure of what it means. So then we need to move further on, and there's one PICO actually measures what's called extravascular lung water, and it actually gives you an objective measure of how much pulmonary edema is there, whereas many of the other ones don't do that, and this works actually quite well. A lot of the intensivists don't trust it, but it does work quite well. Now, so we've gone through all of those things. We know our patient's got pulmonary edema, and of course then we realise that they're going further down the cascade into organ failure, and maybe they've got oliguria, you know how the urine sort of goes off, and then we probably need something really quite invasive like the pulmonary artery catheter, and from that we can measure all sorts of things. We can also measure oxygenation variables, which if you do it properly. The only thing is with the pulmonary artery catheter that your technique with it has to be spot on, because there's so many things you're measuring that if you do something which is not perfect in the whole data collection aspect of things, your number that you get with oxygen consumption and oxygen extraction goes quite off the board. So you need to be well practiced with that. Okay, now deep breath, move in your chair.